So what we're going to do, this is a posterolateral approach. I've just marked the line on the pelvic outlet view just superior to the S1 neural foramina, and I'm marking the lateral back portion of the ilium right here. I put 2 lines here, and then my start point will be right here. And this will be the line that goes across the superior border of the S1 neural foramina, and then the line that goes across the lateral portion of the posterior portion of the ilium right there. So that will be my start point right there. Thank you, Dave. I'm going to make a little incision. And it's not much of an incision. Again, it's just enough to get the implant in. And so we'll come along the posterior portion, picture that, and we see the back part of the ilium, and we can see that we're aiming toward the body of S1, and we're going to just breach the cortex right there. And then I'm going to switch to a pelvic inlet view. So the same thing, except come toward the inlet. So we start in the posterolateral portion of the outside of the ilium, and we can see that this is a pretty good trajectory picture. And we can hear the tone change as we cross the SI joint. Picture that. And can you give me, Anthony, give me a little bit more inletty, which means a little bit more caudal angulation of the II. Okay, good. So we're going to steepen this up just a little bit. Picture that. Good. And I'm going to switch from the diamond tip to the single bevel. Give me a little bit more directional capability. I'm going to mark the direction on this. This doesn't have an indicator, so I'm going to put a mark on the proximal portion of this. Picture. Okay, picture. So I'm going to take a little bit steeper approach. Picture. Good. Picture. Okay, so let's go back to the pelvic outlet view. Okay, good. I'll exchange this for Steinman pin. Great. And we'll retract the jam sheet over the Steinman pin. It's a blunt Steinman pin. And we will have dilator 1. It's also a sizer. Let me have, that's not the system. I'm placing a posterolateral. So let me go with, just leave it there. Okay. All right. So let's just do this. Grab me the longer pin, longer Steinman pin. Picture. Okay. And this is dilator 1. We're going to get size. Give me, let's put a 30, let's put a 40 millimeter screw in there. And I'll take dilator 2. We're not using the posterior approach. We're using the posterolateral kit. And I will take the working channel. We can take either a lateral or a give me a lateral screw if you would. So dilator 1, dilator 2, working channel, I'm going to remove the internal dilators, leaving behind the Steinmann pin.
And next step is to put a screw in. So
While we're doing this, we're loading the implant, let's take a lateral shot. I need a 40 screw, 40, yes. Good. That's about right. That's about where we should be. So this is roughly headed just below the sacral promontory. There's some techniques that show you to hit the sacral promontory, but that doesn't give you the maximum amount of alar anterior extension. So we like this. This is a nice view. It's right at the body of S1. It's above the S1 neural foramina where it comes out. And then let's swing back around to that pelvic outlet view, that oblique pelvic outlet view. And this is going to be a nice final resting position for the implant. Okay. So give me a shot there, if you will. Good. And you'll start to see this is a ratcheted device, ratcheted inserter. You'll start to see the screw coming into sight right there, picture, as we go across the SI joint. There's a drill also that you can use before you do this. Let's switch to the inlet view, please. The inlet view will show you the distal portion where you need to stop before you go through the cortex. But excellent. This is designed to self-tap, and it's also designed to go through the cortex without having to drill. And if I can get away with not drilling, picture, I like to not drill because it gives you a tighter fit across that joint and into the cancellous bone, picture. And Anthony, is there any way to go more inferior? Okay. All right, good. Just mind that anterior cortex right there. Picture, good. Picture. So we'll get the threads from the anterior portion just across that SI joint, picture, and the threads from the posterior portion will be in the ilium side of the SI joint, picture. Arc a little bit more towards you. The contralateral oblique, especially in the inlet view, will give you a shot down the joint. And that looks very nice right there. So with that, I'm going to unhook the implant, and we're going to take the whole thing out, working channel, Steinmann pin and all. And
Doug, can you comment for the fellows on the biomechanics of variable pitched screw implants?
Yes. So what this does, the variable pitch of the threads will have a lagging feature. The ones in front are more widely spaced than the ones in the rear. And let's go ahead and give me an outlet view. And because of that, it advances farther than the ones do in the rear, and it pulls the distal portion to the proximal portion. So this is a nicely steeply oriented screw on the inlet view. We'll take an oblique outlet view. And that's nice right across the joint. Let's take a direct AP outlet, so arc toward me. And then after we do this, we'll take a lateral view just to take a look at it, and then we'll place the lateral screw. Very nice. And let's take a lateral shot. Yeah, so this is designed to lag, and designed to pull each side of the joint together. The screw features of the screw, it's rifled in the inside, it self-taps, it self-augers, it has oval windows, it's made out of 3D printed roughened titanium. And this is a nice final lateral position of the screw. And typically we'll put one in the body of S1 like this, put one in the body of S2 back down approximately where Dr. David's graft is placed, and that's posterolateral portion, posterolateral fusion of the SI joint. With that, I think we have enough room. I kind of put a short screw in there, a smaller screw on purpose, so I really wanted to be able to do the lateral-based SI off of this. And so let's transition over. We're going to do the lateral based with this. All right. So, picture. 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 I'm lining up the greater sciatic foramina. So the surrogates for this, to be lateral, you want the superior end plate of S1 to be sharp. You want the superior portion of the sacroiliac to be lined up and sharp. And the other components you can use is the femoral heads, which are not present on this specimen, but you can line up the greater sciatic foramina. So I'm going to start lateral here. Picture. And the first thing I'm going to do is just take a mark of the dorsal sacral tilt to give you an idea about, so picture, 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 picture. So that's about right there. The dorsal flip of the sacrum is fairly profound, and I use this because superior is actually not this way. Superior is that way to the sacrum. This is dorsal, this is ventral, this is superior, and this is inferior. Sacral, because of the dorsal tilt, you have a different type of guidance system. So let's take a look here. Picture. And so I'm going to go right here in the mid-body of S1, and I'm going to make an incision there, and we're going to place the access along the anterior border of that. That's where the bone is most dense. Along the anterior border, I'll do an exchange here with the Steinman pen. Picture. So I'm going to go just anterior, about right there. Picture, Anthony. So that's a good start point, the anterior body of S1, and the reason why is that's where the bone is densest. And we will go in until we are at the appropriate position. And picture. And we will advance until we get to the joint. I kind of feel that this is probably close to the joint because of the sound. Picture. Okay, let's go back around to a pelvic outlet view. So I can tell I'm right at the joint, and the needle is pretty much down the barrel with the II, so we know we're going on a fairly straight trajectory. Yes, direct AP outlet, exactly. You're hired. So we'll see where we are in relation to everything else. And again, I'm going along that anterior wall because that's where the most dense portion of the bone is. Picture. Good. Picture. Okay. Well, this is partially going to block or obstruct our pen, which is okay. But I'll just talk you through it. And the shoulders of the pen. So I'll place it here, and we'll see what we can see. Picture. Picture. Okay, this is going into the joint. Give me an oblique about 10 degrees toward you, and we'll see what we can see. The pen here is shouldered, and we need to stop before the the shoulders get, let's come back a bit, a little caudal, try to throw that off. Picture. Yes, right there. Can you see the pin is shouldered down? And I want to put the shoulders just proximal to the sacral side and sacral cortex, and that kind of will help protect things as we go forward. Let's see here. So dilator 1, we'll put this in. Okay. And there's a sizer approximately here. It says size D. The hardest part about doing lateral approaches for SI fusion is one's presbyopia. So you can see size D right there, the nice laser hash mark. Great. And we'll finish the dilation, dilating up. And the final dilator. They're tapered on the front and textured on the back, so it's easy to grip and easy to place. And we'll have the extender to the pin. Thank you. And we'll
drill it. Why not? We skipped it on the last one. We'll do this.
So here is the drill. We'll just drill over, picture. Thank you. Picture. Picture. Good. I'm just going to go ahead and come across that joint. Picture. Yeah, good. Okay, shoot that. I like it. And we'll remove the drill. And the lateral-based implant we're using is the Liberty implant by Spinal Simplicity. So I'll trade you the drill for the implant. Here's what the implant looks like. This has threads distally. It's also self-tapping to make its way across. It has wings here that can be deployed. And once the wings are deployed, it provides a 2 centimeter or 20 millimeter footprint in which to compress the sacral side of the cortex, and will tighten it up on the proximal portion of the inserter, and it will bring the two ends together and give it a tight, and it has a collar here up against the ilium so this doesn't slide in, so prevent it functions the same as a washer with the proximal flare that we discussed earlier that I much prefer to a washer. Okay. Wow. Okay. All right, we'll place this across. And before we do that, I'm going to show the wing reference line. It's right here. It's the same thing as on the Minuteman, made by the same company. So the wing reference line will be deployed. We'll have it appropriately deployed or oriented before the wings are deployed. Picture? Okay. All right, picture. Good. picture. All right, a little bit farther. All right. Got a team effort here. Got Anthony helping me out. Okay, picture. All right, good. So put the wing reference line parallel, and we will deploy. Shoot that. Wings are being deployed. You can see them.
Doug, when you say parallel, are you parallel to the floor or are you parallel to the pelvis?
Yeah, well, we're parallel to the joint. So picture that. You can see that, see the wings. So the sacrum is going like this, and the wing reference is parallel to the SI joint and the dorsal tilt of the sacrum. Picture that. So very nice. We can see that deployed just medial to the medial cortical wall. And then the next thing we'll do is we'll compress and tighten this up. Picture that. All right, very nice and tight picture. So you can see that compressed across there. Very nice. And we will unlock this. And pull everything out. All right. Very tight-fitting Steinman pin. So let's take some final shots of that.
Doug, before you proceed, can you stay on that shot? Oh, well.
Say again, Neil.
I was going to point out that all cannulated screw systems, as the screw gets closer to the tip of the Steinman pin, can bend the tip of the Steinman pin.
Yes.
And as you go to try to extract them, they've bound themselves. And when you were pulling the Steinman pin out, you were adding muscle. And that's where that came from. And you can see that on the previous x-ray. The Steinman pin was being bent.
Yes, exactly. It will sometimes bind. In this case, it was binding up as we were hitting the other screw, but there's enough room in there. So this is a pelvic inlet view. We're well away from the anterior border of the inlet. Let's take it a little bit 10 degrees towards you. Get an oblique inlet view down the joint. So we can see it's right up against the ilium. The wings are deployed just medial to the sacral cortex, and that is a very nice look. Let's take one final lateral shot. So this is the placement of a lateral Liberty implant. And this is also a hydroxyapatite coated, cannulated, self-tapping titanium alloy screw. Very nice. Perfect position. Questions, comments?
Yeah, could you just discuss the superior gluteal artery and how you avoid coming into contact with that vessel?
Yeah, so superior gluteal artery, the risk of hitting that and having something that needs to be done about it is 0.04%. So it's exceedingly unusual. People way overemphasize the superior gluteal artery. The way to avoid that is don't go at the foramen of S2 or below it. And you don't want to go too far anteriorly. Of course, you don't want to go too far anteriorly because that's where the lumbosacral trunk is. If you miss with a lateral SI joint fusion, it's a bad event. It's like a brush back pitch from Nolan Ryan. If you're going to miss, it's high and inside. So you don't want to go too far superior. You don't want to go too far anterior. And the superior gluteal artery tends to run at the foramen of S2 and below, and then anterior. So functionally, I really wouldn't worry about it too much. All of the superior gluteal artery disruptions have been with one device, and it's not been reported with other lateral approaches.
Okay.
Awesome.
Thank you, guys.
Thank you, Dr. Beall. That was awesome.